Yeah, the angle, I mean, I suppose it could be less than 90 degrees if you don't pull it flat against the abdominal wall, and that's what I was asking, because some people tend to let it sag a little bit more in the middle, so it's more of a gradual angle, and that may exert more force pulling the mesh back into the abdomen. But I'm curious about those sutures, because I hadn't heard that. To put in sutures that you might go back and remove later, are there intracorporeal sutures, so where would you make your incision to loosen them? I'm just not sure I'm clear.
Right, so transfascial, obviously the sutures are transfascial, but I mean, you know where the exit side of the sutures is, so you could, you don't have to go back to the operating room, but you could enlarge that incision maybe and take one of them out. I think my partner, Dr. Henford, had to do it once in the past, and that's the extent of how often we had to use that mechanism.
Okay, interesting. Thanks. Let's see. We've got some other folks we can pick on. Maybe if we go up to Dartmouth Hitchcock Medical Center, what's your preferred approach for hernia repair or hernia or stoma relocation?
Hi, this is Gina Adrales at Dartmouth. I'm not a fan of the stoma relocation. I do adopt the sugar baker repair, and I think it's very useful in these cases because often these patients also have a midline incisional hernia, and so the mesh can cover both areas. The obstruction, you know, one wonders when you construct it, you worry about the obstruction just from the way the bowel lays. And angles, and I like to visually inspect that just to see where the bowel will come in naturally, you know, and exit laterally. But I think it's important to remember that this is still a hernia, and what we really have to adhere to are principles of hernia repair. So it's important to make sure you have adequate overlap from the actual hernia defect, which is where that stoma exits through the fascia. And so I typically will make sure we have at least 5 centimeters overlap from that central site outward. Now, the only stomas I think that are a little bit more tricky in terms of obstruction are the urinary conduits. Those can be a little bit more temperamental, and you have to be careful with those. But I haven't had any trouble in terms of other ostomies.
What kind of material do you like to use?
I use the dual mesh, the Gore-Tex.
Okay. And then lastly, let's go to Strasbourg, France, and ask at IRCAD what's the preferred method of approaching parastomal hernias, whether you relocate stomas or if you repair them, and if so, how?
Yes, hello. Michel Luc from Strasbourg. We try to relocate the first if we can, because you show that the recurrence rate is lower when you are recollecting on the other side. But in some cases, we tried to do by laparoscopic approach the closure of the defect by intra-abdominal with a dual mesh. And since yet we have good results for that. But like you say, there's, I think, not one best technique. You have to adapt in function of the case and the length of the colon and the previous surgeries the patient had.
So that's interesting. So a vote for relocation. And have you tried the technique for relocation where you make a parastomal incision and just bring it across to the new site? Or do you, if there is a prior laparotomy incision, do you reopen it? Because there's you actually go in the belly, or you can go parastomal.
We go through the orifice of the stoma first, and we can convert to a laparoscopic approach just to remove the adhesions that we can have for making the way going on the second side. And in some cases, of course, you need some length, more length of colon, and so you have to free the upper angle, the left upper angle, and that can be done very nicely with laparoscopic approach.
Yeah, I think that's an important point, that you don't have to make a big incision. You can do this through the stoma site and perhaps aided by laparoscopy. I agree with you on that one. So let's go back to the presentation, and then we'll get back to some more questions shortly. We also had 2 more sites tune in, Centaur Lee Medical Center, and also the University of South Carolina at Greenville Hospital System.
Okay, so let's just turn our attention to prevention of parastomal hernias. This recent meta-analysis of 3 randomized prospective trials using mesh to prevent parastomal hernia formation did show significantly decreased rates of parastomal formation, 15 versus 55%, in patients who did receive mesh implantation at the time of stoma formation. Basically, it was shown that it was safe, and it did decrease risk of hernia formation. The same set of data was used by another investigator to look more specifically at the recurrence as well as need for surgical intervention after the hernia recurrence. These are the 3 same randomized trials that Dr. Tam et al. Looked at. So you can see that the first trial looked at loop-ileostomy, the next 2 looked at end colostomies, and the mesh used, you can see, it was first one was Biologic porcine mesh, second one was a Prolene and Vicryl, and Prolene and Monocryl was the third one. So basically, when it comes to prevention of parastomal herniation after mesh reinforcement, again, the results favored mesh placement. And when the development of parastomal hernia requiring surgical repair was examined, it also favored mesh placement. So the authors concluded that mesh placement was associated with reduced incidence of hernia and no excess morbidity, as well as a trend toward decreased incidence of herniation that required surgical intervention. Another study from last year looked at prophylactic mesh placement in 93 consecutive ostomies. The authors have a 1-year follow-up. They used a low-weight absorbable mesh in the sublate position as described previously. Basically, 75 out of the 93 patients received mesh, and in 19 of those 75 patients, there was actually severe contamination during the case. And interestingly, the surgical site infections were not associated with mesh placement. However, others have, and I'm sure we all have seen, the issues that synthetic mesh brings to colonic surgery or any bowel surgery. There's certainly an increased risk of surgical site infection that are difficult to treat. There's also potential for visceral adhesions, bowel obstructions, and fistulization, and also chronic body response, foreign body response has been described. And of course, we all have seen mesh eroding into the transverse colon 5 years after someone had their hernia repaired. Also, reimplantation into the contaminated area does result in a higher rate of infection, and overall, the literature contraindicates synthetic mesh placement in clean contaminated cases as well as in dirty surgical fields because of the above risks. So, how can we deal with that? One of the ways that has been looked at intensely and is being continuously examined is the use of bioprosthetics. Dr. Ellis last year looked at a cohort of 20 patients with a bioprosthetic mesh placed via the sugar baker technique. And he followed the patients for an average of 18 months. Basically, he only saw 2 recurrences with no infections, and 4 seroma were present that were easily treated on an outpatient basis. Now, when somebody thinks about an ideal mesh that could be placed to prevent hernia formation, Shankaran described recently the 8 characteristics that should be associated with it. It includes the fact that it should not be carcinogenic, chemically inert, resistant to strains, capable of being sterilized, of course, relatively inert, and capable of limiting foreign body reaction, as well as amenable to fabrication and unlikely to produce allergic reactions. Now, the bioprosthetic mesh also contributes 2 other factors. It is resistant to infection, and it does provide a barrier to adhesions. So this table quickly summarizes the characteristics of prosthetic meshes that have been used, and you can see that the Biologics seem to have the widest spectrum of effect. We already addressed this a little bit earlier in the talk, and this is just a sample of the meshes that are available out there. We're not going to go into that anymore. So,
thanks. So, you know, what it seems to show is a potential shift from synthetic mesh to biologic mesh because of the potential risk of contamination. Well, you know, so that raises the issue, can we somehow prevent herniation by prophylactically putting in mesh, which would be a paradigm shift to go away from just repairing these things, which can be singularly ungratifying, to trying to prevent them. So let me turn first back to IRCAD in Strasbourg, they're still online, and ask, if you are going to move a stoma, you know, parastomal hernia, you're now going to move the stoma to the other side, would you at that point put in some type of prophylactic mesh to try to prevent hernia formation, or just make a new stoma?